Hello, and thank you for joining us. This presentation is a supplement to the very brief talk I gave to the Virtua Medical Group on October 6, 2016. We will discuss the role of transoral robotic sleep apnea surgery for snoring and obstructive sleep apnea. Light snoring is funny on television, but loud snoring and obstructive sleep apnea are potentially fatal if untreated. If you have a patient who comes in with these particular symptoms, you should consider sleep apnea as a cause. Excessive tiredness, unexplained headaches, new onset of atrial fibrillation, a patient who's chronically sick or complains of sexual dysfunction. If they have any of these, ask them about snoring, gasping, choking, stoppages of their breathing, and, if possible, ask their bed partner as well, because frequently the patient doesn't know. They just know they wake up tired. Now, severe snoring and apnea actually represent a multi-level obstruction much of the time. We should consider problems in the nose, the throat, aggravated by swelling from reflux, and we'll briefly discuss extra weight of the chest and belly. First, let's look at the nasal exam. If you suspect sleep apnea and you look in the nose and see a severe deviated septum, like on the left, or if you see very swollen allergic type turbinates, as seen on the right, you should consider that this contributes to their sleep apnea and sleep problems. A mouth exam frequently will show severe fissuring and inflammation of the tongue or a geographic tongue. These are signs of reflux from the stomach. We also evaluate the patient's mouth. We look for the size of their tongue, the size of the tonsils, and the size of the palate compared to the space in the mouth. And of course, a patient who's big, either their BMI is high because of fat or a lot of muscle. Many players in the NFL have obstructive sleep apnea, and they're certainly not out of shape. The optimal BMI is up to 25. A BMI higher than 25 is categorized as either overweight, obese, or severely obese. And coupled with the other airway obstructions we just mentioned, these could contribute to obstructive sleep apnea. We evaluate the patient's airway and airway by putting them in the supine position and looking with a scope at the nose, the throat, and the voice box. We put them through various breathing maneuvers to simulate the collapse of the airway which occurs during sleep. We can then map out for them where they're blocked and prioritize treatment. If they don't already have a sleep study, we should consider a sleep study for these patients, either an in-lab study, or here this is showing a home sleep test. That will document whether patients do or do not have obstructive sleep apnea and the severity of the apnea. Now, if they've been diagnosed with sleep apnea, the first line of treatment is medical management. We treat their allergies, we treat their reflux, we discuss diet and weight loss, diet and exercise for weight loss. If this is successful, if we can improve breathing through the nose or through the throat, and particularly if patients can lose weight, absolutely their sleeping will improve. If this does not work, or it's not satisfactory in the degree of improvement, then we should think about devices, and there are two particularly, CPAP and BiPAP, as shown on the left. This pushes air past any obstruction. The disadvantage is that the greater the obstruction and the greater the resistance, the higher the pressures are required for improvement. And this makes it more and more difficult for patients to tolerate it. On the right, we see a mandibular advancement appliance. It's a type of a mouth guard that patients wear at night. It pulls the jaw forward, and in so doing, it also pulls the tongue forward. If devices work, or a combination of medical management and devices work, then patient's going to be healthier. However, if it does not work, we should think about surgical options. Now, someone who is severely obese may benefit from bariatric surgery. In our office, we talk about upper airway surgeries. This patient on the right has a distorted nose, both internally and externally. We did a reconstruction of his septum, turbinates, and outside of his nose, and his sleep apnea was actually cured just by his nasal surgery. Patients with big tonsils and palate can have their tonsils removed, the palate trimmed and moved forward. If they also have collapse of the base of tongue, that's the hypopharynx, I can't get my hands into the back of their mouth. However, with the robot, we can. So we frequently will do oropharynx and hypopharynx surgery together, and that's called transoral robotic sleep apnea surgery. Here's a picture in the operating room with me performing TORSA. The patient is asleep on the OR table. The robotic assistants are at the head of the bed, and I'm in the back with the surgical console. I look in the console and see three-dimensionally what's in the back of their throat, and I can manipulate the instruments to do several procedures. The diagram on the left shows how we remove the tonsils and trim the palate, and on the right is a 3-month post-op picture showing how dramatically improved the airway is. And we can dress the tongue. On the left, you see the back of the tongue is very swollen. That's actually lymphoid tissue or lingual tonsil tissue. If this is the patient's problem, we trim that tissue and it heals flat and improves the airway. Other patients have a large tongue or a small mouth, and in this case, for them, we remove the central tongue tissue using the robot and then suture the membranes closed. That automatically makes the tongue smaller and makes the airway larger, and as healing happens, the airway gets even larger. The amazing thing about this type of procedure is if this is the only thing we do, patients virtually have no pain after. It's amazing. We do this procedure in the operating room, general anesthesia, takes about an hour and 20 minutes to an hour and 30 minutes. And post-operatively, we admit them overnight. We ask pulmonary critical care to consult on the patient, and this they monitor their capnography and pulse oximetry. We give the patients IV fluids, pain meds, and antibiotics. For their reflux, we'll maintain their PPI or add Carafate to gargle and swallow. We give them their own humidifier and ask them to eat, typically bland, soft foods. We expect them to go home the next morning. If they are still symptomatic in 3 months post-op, or if they had severe obstructive sleep apnea pre-op, we always get a repeat sleep study at approximately 3 months. Also, the patients who did have severe OSA pre-op, we ask them to wear their CPAP, but we typically reduce the pressures during the healing process. Now, how do these patients feel after their procedure? They all have a sore throat if they've had the palate work done or we shaved lymphoid tissue from the posterior tongue, and that lasts approximately 1 to 2 weeks. they all have abnormal taste for up to 3 weeks, and this comes from swelling of the glossopharyngeal nerve in the hypopharynx. They feel themselves swallow for up to about 6 weeks, and this eventually goes away as the tissues soften up. Right now, you can right now you can swallow yourself and realize, oh, you don't really think about it. Like you'll eat dinner and you'll be engrossed in conversation. You don't think about your swallowing. But after the tissues are trimmed and sutured, and as healing happens, the patients feel themselves swallow. So I tell them to be aware of this, and eventually it goes away. But with these negatives come positives. Even in PACU, these patients don't snore. They all feel better rested, even the ones who still have some sleep apnea. And typically the bed partner is very happy. So I want to give you a brief review of the results of my first 43 patients undergoing TORSA. They were 2/3 men. They ranged in age from 19 to 78, and they were obese, moderately obese, or severely obese. AHI and RDI are signs of pauses in the breathing. Preoperatively, they averaged 30.5, and postoperatively averaged 17. The lowest oxygen reached preoperatively was 79%, and this improved to 86% post-op. Out of these 43 patients, I had one who actually got significantly worse despite the procedure, but he gained so much weight that I realized that TORSA cannot compensate for massive weight gain. I was particularly happy that more than half of the patients had complete success from TORSA. No signs of apnea without CPAP. They all voluntarily reported that they were dreaming again, and this is a sign of getting into REM sleep. They had energy, alertness when they woke up and throughout the day, and the bed partner was always happy. Now, there were also 18 patients who had success, but partial success. And these were all patients that were moderately or severely obese. They did have improved sleeping, improved energy and alertness, and the partners were happy, but we had them continue to wear their CPAP, but at least at a lower pressure, so it was easier to tolerate. We had one carpenter who had his procedure on a Friday and went back to work on Monday. He said he had a sore throat, but hey, he was going to sit around the house and not make money versus work like he wanted to, and you know what? He did fine. We had a dentist go back to his practice in 10 days. We had the 78-year-old patient play tennis 2 weeks after her procedure. I did have 4 complications out of this group. 2 patients had what I consider prolonged pain and sore throat. One of them had to be readmitted to the hospital on 2 occasions for IV fluids, and eventually he improved. But looking back at his case, I didn't do anything different for his procedure, but he did have a long history of lower back pain, and he'd been on pre-op narcotics for that. And I wondered if I should have done a better job of counseling before the procedure. I did have one patient with significant scarring in his throat, which required a revision procedure, and that eventually got better. There was a patient who reported that she had bleeding, but yet when I saw her in the office, there was no sign of that, and we never actually witnessed it. To summarize, I would say it's important to perform a complete evaluation of the airway. And you can do this yourself, and we can do it in our office with a scope. Look for tongue blockage as well as big tonsils and a big palate. And consider that It's a multi-level disease, and it needs a multi-level cure. Frequently, medical management and devices and surgery are helpful. Turns out TORSA benefits most patients who failed previous tonsil and palate surgery, but it cannot overcome massive obesity. However, it can allow patients, these obese patients, to use their CPAP at a lower pressure. The exciting thing for me is that Virtua is the only hospital in the state which offers this TORSA procedure for their patients, and I'm proud to be able to do it for them. If you would like TORSA brochures for your office, or if you have any particular questions about a patient or would like to refer a patient to our office, here's my contact information, and we certainly look forward to seeing them for you.